Good morning. Where are you guys? You guys just finished boards, is that right?
2 months. 2 months out.
2 months ago. Is anybody studying for oral boards, or are we all residents? All right. Well, you need this. This is a huge topic. Vertical incompetence deviations is what we're talking about today. And it's a huge topic, a wealth of information. But the most important thing, I'll try to make it as interesting as I can. Some of it's a little dull, but the most important thing is this is a huge topic for boards. So I'm going to try to point out areas where I know they target for boards, because those are the areas you're going to definitely need to know about. Well, let's review. Common in strabismuses are deviations that are same in all fields of gaze. Hopefully you all know that about this time. They're not usually associated with neurological diseases. Incomitant strabismuses are those that are limited eye movement in different deviations in different fields of gazes. This is due to restriction, both periocular scarring or tight extraocular muscles, or neuromuscular paresis, the third, fourth, and sixth nerve palsies. Vertical deviations occur in 5% of all strabismuses, so they're relatively uncommon. They're described according to the direction of the deviated non-fixing eye. So if the eye that's fixating is the left eye here, and you've got a right hypertropia, or vice versa, you may have a hypotropia in the deviating non-fixating eye. They can occur alone, or they can occur with horizontal deviations. Most vertical deviations are incomitant. They occur from over or under action of the superior oblique. They can occur from paralysis or paresis of the cyclovertical muscles. There can be restriction of vertical movement, for example, in thyroid disease or blowout fractures, and they usually become cominant with time. Okay, that's an important point, because if they're long-standing, you will see a lot of cominance and it'll be hard to target which muscle is causing the problem. So one thing to make these vertical deviations a little bit more self-explanatory and understandable is just to remember the actions of the oblique muscles, okay? Rather than memorizing all this wealth of information, all these V patterns, A patterns, remember the actions and go back to the simple basic actions of the oblique muscles. Remember the inferior oblique, it elevates the eye, it extorts the eye, and it abducts. Okay, and those are important actions you got to remember. The superior oblique infraducts the eye, it intorts the eye, and it also abducts. Okay, and so when you look at these type of deviations, think about those actions. Okay, so the first vertical deviation we're going to address is the inferior oblique muscle overaction. In primary situation, you just have an over-elevation and adduction alone. And in a secondary deviation, you have an associated superior oblique paresis. So the superior oblique isn't working, so the inferior oblique, the antagonist, is overacting. You see this, a V pattern in horizontal deviations, okay? So you don't need to memorize a V pattern. If you think about the action of the inferior oblique, if it's overacting in up gaze, it's going to abduct more. So it develops a V pattern, okay? And you see in the bottom picture here, significant overaction of the inferior oblique muscle. We grade these overactions by the position of the limbus with respect to the limbus in the other eye. In this situation, it's about a 3+ overaction. You see about 3 millimeters of limbus there compared to the other eye, and you can see significant overaction bilaterally. There we go. The clinical features of inferior oblique muscle overaction, they usually occur between the ages of 1 to 6, and you'll see this in about 2/3 of patients with congenital esotropia. Now that's a board question. When you start talking about congenital esotropia, and this was on my oral boards, is they want to hear about inferior oblique overaction, okay? And they want you to tell about it, what you'll see in it, and they want you to know how to treat it, okay? And also the features of it. It's the inferior oblique overaction is less frequent in acquired esotropia, exotropias, and when there's no strabismus. Well, strabismus being that it may be isolated inferior oblique overaction. That doesn't happen as often as with esotropias. It can be asymmetric and frequently is asymmetric. And in lateral gaze, you'll see the higher eye refixate with a downward movement and the lower eye refixates with an upward movement. So this is a true hypertropia inside gaze. This differs from a dissociated vertical deviation, and that's a good clinical point to remember, because in a dissociated vertical deviation, you won't have that refixating hypotropia, okay? You'll only have that refixating hypertropia. With bilateral inferior oblique overaction, There's higher and lower eyes reverse direction in the opposite lateral gazes, okay? So you'll have a, upward position in this gaze, upward position in this eyes, and the hypertropia will, as you do your cross-cover test, will reverse. The management, most of the managements of the vertical deviations, in board questions, you don't need to discuss in detail, but you need to kind of know the terminology. For example, in inferior oblique overaction, they'll ask you, what would you do for it? And you have to discuss, minimally at least, the weakening procedures that you can use. You can recess the inferior oblique. You can just insert the inferior oblique. You can do a myectomy, where you just cut through the belly of the muscle. You can denervate the inferior oblique and then extirpate or take the muscle out of the eye completely. And you can do an anterior transposition. The anterior transposition is frequently used when we have inferior oblique overaction with an associated dissociated vertical deviation. When you do an anterior transposition, you're actually taking that inferior oblique and you're transposing it to the lateral border of the inferior rectus muscle. In this situation, you want to watch where you place that insertion. We frequently make that insertion kind of bulk it up rather than spread it out, because the lateral portion of that insertion, if it's placed too laterally, can create an anti-elevation syndrome. Also a board question. And they don't ask you a lot about anti-elevation syndrome, but it's kind of, you see that on the written boards as one of those answers that you'll have. But anti-elevation syndrome is where you place that insertion too much laterally, the patient goes into abduction and they can't elevate the eye, and that's anti-elevation syndrome. Weakening the inferior oblique has little effect on the horizontal alignment, so that's kind of interesting because you can do a lot with the inferior oblique without affecting the primary position frequently. In superior oblique muscle overaction, all cases are considered primary, as inferior rectus and inferior oblique paresis is uncommon. The clinical features are that the vertical deviation in the primary position with unilateral or asymmetric bilateral superior oblique overactions. So there's a vertical deviation there, okay? It's usually associated with a horizontal deviation. Exotropia is most common. And there's usually a hypotropia of the adducting eye, which is worse in down gaze. Again, thinking about where the superior oblique acts. It acts in down gaze, and you'll see a significant more hypertropia there. This is showing superior oblique muscle overaction. I'm sorry if I said inferior oblique muscle overaction. This is superior oblique muscle overaction, and you can see it right here. Again, grading this response, it's about a 2 to 3 plus overaction. This is maybe a 3 plus to almost 4 plus overaction, about 3 plus overaction here. And you can see that the inferior oblique underaction in these situations because of the antagonistic overaction of the superior oblique, and an underaction as well here. In weakening the superior oblique overaction, you want to think about recessions of the superior oblique muscle, tenotomies or tenectomies, okay, and these can be partial or complete tenotomies or tenectomies. You can lengthen the tendon, which will weaken it. A silicone expander can be placed within the tendon of the superior oblique, causing length and consequently weakening. You can also use a non-absorbable suture to lengthen the tendon, and you can Z-split the tendon as well to lengthen it. It's important to remember that when you're doing surgery on the superior oblique muscle, patients with binocularity can have significant torsional and vertical effects from weakening the superior oblique. So you want to be very careful because these will cause torsional diplopia, which can be very difficult to treat. Dissociated vertical deviation is another one of those board questions you want to talk about when they talk about congenital esotropia with you. And that, again, is a common board question. These occur in about 50% or more of infantile esotropia, so very common. They also occur in other forms of strabismus, and it's due to an innervational disorder. Again, looking at the picture of a dissociated vertical deviation down below, you can see when the dissociated vertical deviation eye fixates, you don't see that. When the other eye fixates, you see the dissociated vertical deviation. The clinical features of the DVDs are that they present after age 2. And you can see clearly here, the eye drifts up and out when occluded or with visual inattention. So under the filter occluder here, you can see the eye drifting up and out. Almost looks like an exotropia, but there's a vertical component in there as well, and you can see it here as well. So be sure to don't mistake those as exotropias. Okay? Again, you'll see the refixation downward without the associated hypotropia of the other eye, refixation. Dissociated deviations, dissociated vertical deviations have no corresponding hypotropia, as I just mentioned, when the hypertropic eye refixates. They're usually bilateral and they're frequently asymmetric. They are most commonly vertical, but they can be horizontal. A dissociated horizontal deviation can occur. They occur spontaneously and is a manifest dissociated vertical deviation, or with occlusion where you'll see a latent DVD. They're often associated with latent nystagmus and horizontal strabismuses. And you measure them with base-down prism over the deviated eye. So you keep adding base-down prism until there's no downward movement and to refixate. They're a little tough to measure with prism bars, but if you use loose prisms, you'll be able to measure them, I think, more easily. The management of DVDs are to treat them if the deviation manifests frequently. Frequently, you can change the fixation preference by penalization. As I showed you on the previous slide, if they fixate with the DVD eye, they won't manifest the deviation. So if you can change their fixation preference by penalization or blurring, sometimes that'll control the deviation. You can also do surgery on the vertical recti. However, this improves the condition, but usually doesn't eliminate it. You can also do, as I said, the inferior oblique anterior transposition, again, watching for that insertion to prevent anti-elevation syndrome. Superior oblique palsies are another common form of cyclovertical muscle paresis. In a congenital superior oblique palsy, this can be secondary to an attenuated or lax tendon. It can be a misdirected tendon, an absent tendon. It can be due to orbital pulley problems or craniofacial abnormalities. In cases of acquired superior oblique palsy, you'll think of closed head trauma, CNS vascular abnormalities, diabetes, and brain tumors. And this was a great picture because this girl presented both with her doll and her having a superior oblique muscle paresis, as you see. Great picture. In a congenital superior oblique palsy, there's usually compensatory head tilt, and this is due to the eyes trying to achieve fusion. And you'll see this to the side opposite the palsy. Frequently, this will cause facial asymmetry if it's been long-standing, where they'll get shallowed and atrophied facies on the dependent side. So on the side that's down, you'll see that the facial face is asymmetric and atrophied. There's usually large vertical amplitudes when the superior oblique palsy is congenital, okay, because they're trying to fuse, and if they move out of that head tilt position, they start developing incredible fusional amplitudes because they're trying to achieve fusion, and consequently they'll have good stereo vision. So you want to look at old photographs for a previous head tilt in a patient. In an acquired situation, not attributed to trauma, this will signify that you'll need to do a neurological workup. And again, those fusional amplitudes in an acquired situation usually are much less.
What age do you consider it acquired? Like when you're, if the patient is kind of unclear, they're 5, and old photographs are kind of equivocal, you send them to neuro?
Again, if the photographs are unequivocal, you're going to check for the fusional amplitudes of the patient. Okay, if they have large fusional amplitudes, it almost means it's congenital. Okay, because you're not going to have, and with an acquired superior oblique palsy, you're not going to have large fusional amplitudes. They're going to be very small. Remember, it's very difficult to fuse the vertical deviations in anybody. We don't have large fusional amplitudes, and when you see 14 diopters of fusional amplitudes, it can only be a long-standing deviation. So that's probably your biggest indicator. Now, on a 5-year-old, that may be difficult to measure, depending how good you are and how cooperative the kid is. Okay. The clinical features of superior oblique palsy are that there's in the normal or affected eye can be fixating, either one. Okay, so you may see the palsied eye fixating. I frequently do, actually. They have hypertropias and excyclotorsion of the eye. Remember, the action of the superior oblique is a depressor and an encyclotorter, so it's just opposite of that. It'll show underaction of the superior oblique and overaction of the inferior oblique, the antagonistic inferior oblique. If the depression can't be evaluated, for example, you have a third nerve palsy, you're going to look for intorsion of the eye when the patient looks down. Okay, if there's no intorsion, you may have a superior oblique palsy as well as a third nerve. Okay, again, when you evaluate your retina, you're looking for that intorsion on your indirect ophthalmoscopy. Okay, remember also you're going to see an upside down and backward picture, so it's not going to look just like this. Hopefully everybody knows the three-step test. That's not one that you need to know for boards or need to talk about in boards, really, but it is one you need to know clinically, okay? The three-step test deals with the 8 cycle vertical muscles and the imbalance between them. In the first step, remember, you're just dealing in primary position, which muscles could cause a hypertropia. It's either the depressors on the hypertropic eye or the elevators on the other eye. In the second step, you're going to deal where the hypertropia is largest inside gaze. Okay, so this just reduces the muscles to 2, whose action is strongest in the field of the greatest in the side gaze. And in the third step, it's going to deal with the torsional component. It selects the muscles whose elevating weakness is exposed when torsion is used. Okay? So the most important thing for boards you need to remember is you got to talk about marching palsies. Superior oblique palsies are marching palsies. They go right, left, or left, right, left. Okay? A right superior oblique palsy will be a right hypertropia, worse in left gaze, worse in right head tilt position. Okay? So they're marching palsies. Left superior oblique palsy will be a left hypertropia, worse in right gaze, worse in left head tilt. Okay? So if you remember that, you can discuss that. You're golden, okay? You'll need to know that for your written boards to quickly answer the questions, though, because you'll see that they'll describe a marching palsy on your written boards, and you can quickly answer the question remembering that. You'll also be measuring the torsion with double Maddox rod, and this is actually difficult to measure unless you have a really good what are these called, trial frame. But in the old, which I think we still have one old 4-opter, it's marvelous to remember it. So remember, when you get on to the clinic, either with me or one of the attendings, look at one of the old AO 4-opters because they have a really great way to measure torsion on those. Unfortunately, most of us have replaced our old AO 4-opters with newer ones which don't have this good double Maddox rods that you can slide around easily. So here's a superior oblique palsy, and this is a right superior oblique palsy. You'll see that the right eye is elevated, worse in left gaze, more elevation in left gaze, and worse in right head tilt position. Okay? So right superior oblique palsy. You can see the significant, when they go into down gaze, a significant decrease in depression there. Okay? The clinical features in a unilateral superior oblique palsy, there's little, if any, V pattern, again, because you've got just a unilateral situation. Again, usually less than 5 degrees of X-cycle torsion, so that's going to differentiate that from a bilateral situation. This 3-step test yields a positive result for the involved side only, okay? So when you tilt the head to the right, with a right superior oblique, there's going to be a right hypertrophy. If you tilt the head to the other eye, you'll see it reduce, okay? And you'll get abnormal head positions are common. They'll tilt towards the opposite side of the weakness, again, trying to achieve fusion. Amblyopia is common in congenital, but not in acquired. Frequently acquired deviations will have diplopia, and that's another way to differentiate it, because the kids will come in complaining of double vision even at 5. In a bilateral superior oblique palsy, you'll see a common V pattern. A V pattern is very common. Okay, why? Again, thinking about those actions of the superior oblique, they're abductors in down gaze. So if they can't abduct in down gaze, you'll get a V pattern because you'll get an esotropia there. There'll be at least 5 degrees of X-cycle torsion in a bilateral superior oblique palsy, but frequently much more, and greater than 10 degrees or more is diagnostic for a bilateral superior oblique palsy. The 3-step test will yield positive results in both head tilt positions, a right hypertrophy in right head tilt, a left hypertrophy in left head tilt. Okay, and you won't see that in a unilateral. And they'll complain of tilting objects in acquired cases. Bilateral fundus X-cyclic torsion will also be seen, and as I said, an esotropia in down gaze because of that lack of abduction in down gaze. So look for bilateral superior oblique palsies with closed head traumas. The management, you'll treat them with prisms if there's a small hypertropia without torsion. Okay? With torsion, very difficult to treat without surgical management. But a small hypertropia, if it's just a small paresis, you can treat them fairly well. A larger hypertropia won't work with prisms because of the incompetency. You'll do also surgery for abdominal head positions, for a large hypertropia, for diplopia, or for aspenopia, or torsion. Sometimes there's a very small deviation, but a significant amount of torsion. In situations of superior oblique palsy, you'll think about weakening the antagonistic inferior oblique. That's a very common surgery. You'll, depending again how much overaction of the inferior oblique you have, you'll recess the contralateral yoke muscle, the inferior rectus. You can tuck the weak superior oblique, or in a long-standing palsy, you may want to recess the ipsilateral superior rectus. Remember, in a long-standing palsy, that deviation will become cominant, and recessing the ipsilateral superior rectus is a very good technique surgically. When there's predominantly torsion, you want to know the hit word Harada Ito procedure. That'll be a board question, okay? This is where, and again, you don't need to understand that thoroughly, but you need to have that hit word there. But that's where you take the anterior fibers of the superior oblique, you'll move them over to the lateral rectus muscle to increase the encyclical torsion because of the lack of that with the paresis. And you want to obviously think about avoiding overcorrection so you don't create a hypotropia after a superior oblique palsy repair. Duane syndrome, another type of vertical deviation. This is due to an innervational abnormality with anomalous co-contraction of the medial and lateral rectus muscles. And here you'll see retraction of the globe in adduction, and this is a really good picture of it. You'll see this child has fairly good primary position. In adduction, you can see the palpebral-physial lesson because of the significant retraction. He's got reduced adduction in that position. And he goes into a lateral movement. You can see also a reduced abduction. So that's a type 3 Duane syndrome. Most Duane syndromes are sporadic. 5 to 10% occur with autosomal dominance inheritance. They're more common in females and more common in the left eye. 15% can be bilateral. And this is secondary to the nucleus of the sixth nerve being absent or malformed. And you can get aberrant branches of third cranial nerve innervating the lateral rectus muscle. And here again showing a decreased adduction, normal abduction, and that's a type 1. So there's 3 types of Duane syndrome. Type 1 is the most common. It occurs in about 50% to 80% of Duane syndrome patients. That's where there's decreased abduction and frequent esotropia in primary position. In type 2, it's decreased adduction, usually a exotropia in primary position. Type 3 can be a little bit difficult because they have both decreased abduction and adduction, and they can have an esotropia, exotropia, or orthophoric in primary position depending on the relative decrease in the abduction and adduction. Okay? Here's showing another Duane syndrome, and this is type 3 with downshoot. Look at the left eye here. When they go into adduction, they can't fully adduct that eye, but you see the significant downshoot that occurs. And these could get fairly gross appearing with very significant upshoots or downshoots. Obviously, those need to be surgically corrected. The surgical management, where you want to deal with any primary position deviation, again, for esotropia, exotropia, in the 2 cases I already mentioned. Certainly, a lot of Duane's children will have significant face turns, and you'll want to try to correct the deviation to correct the face turn. They can have marked lobe retraction. They can also have a large upshoot or downshoot, which we already talked about. In type 1, where there's an esotropia present, you'll want to recess that medial rectus of the involved eye. For a large esotropia, you may need to resect both medial rectuses. For type 2, you'll want to recess that lateral rectus for an exotropic eye. And again, with a large deviation, you want to consider recession in both lateral rectuses. And then for type 3, again, depending on the position of the eye, you may need to do a recession of the medial rectus and lateral rectus if there's a significant globe retraction. And you may need to titrate that accordingly, depending if there's an esotropia or exotropia present. Brown syndrome is another board question. Lots of board questions from these vertical deviations. It occurs from anomalous tendon trochlea complex. So the superior oblique cannot slide through that trochlear complex well. Most are congenital. They can be secondary also to trauma, systemic inflammatory conditions, and sinusitis. 10% can be bilateral. You'll see spontaneous improvement in Brown syndrome in about 75% of the cases. So watch for that as well. So you may not want to correct it depending on the deviation or how significant it is, because a lot of them will disappear on their own. The clinical features, they'll have decreased elevation in adduction. There will be a positive forced duction test because of the restriction of that trochlea. And there's usually a V pattern present. So when these guys go up in up gaze, there'll be a divergence that occurs and causing a V pattern. In mild cases, there's usually no hypertropia, but in severe cases, there'll be a downshoot in adduction. There'll be a hypotropy in primary. There'll be a consequent chin-up positioning for the patient trying to achieve fusion, and they'll turn their face away from the affected eyes, and obviously that'll be a surgical correction. In management of Brown syndrome, you want to observe them if they're mild, and you'll see they'll have resolution of treatment for the systemic condition. Sometimes will help the Brown syndrome with steroid injection near the trochlea, or again, just treating the systemic condition causing the inflammatory condition. You'll want to do surgery for yes?
You talked about with superior oblique overaction, sometimes you see a resultant weakness of the inferior oblique. Can that ever sort of, and then in severe Brown's cases, you can get a downshooting of the eye and abduction. So can the two ever, I mean, I guess forced ductions would be the way to tell the difference.
Forced ductions is the way to tell the difference in a complex situation, but on elevation, you'll see an abduction, a V pattern in Brown's, okay? So you're going to look for that, okay, with an inferior oblique, and there's not frequently an inferior oblique palsy, okay? So
relative weakness.
Yeah, there'll be only a relative weakness, so you'll frequently have a superior oblique overaction with an underaction of inferior oblique, which you won't have with Brown syndrome. That's very uncommon. Okay, so you won't see that superior oblique overaction in down gaze. Okay.
What's in Brown's? When you said they would downshoot an abduction? Could that look like superior oblique overaction, or would it look different?
No, it'll look different.
Okay.
Yeah, it doesn't look like superior oblique overaction at all. Okay. So surgery for severe cases, you'll want to consider ipsilateral tenotomy, nasal to the superior rectus muscle. Okay, so just basically going through and just clipping that superior oblique tendon. You can also do tendon expansion with a silicone rod, or as we talked about, the non-absorbable sutures. That's frequently done as well. So here you go, inferior oblique muscle palsy. They're wondering whether that actually exists, okay? As an abnormality of the inferior oblique muscle certainly can exist. Here you see a hypotropic eye is encyclotorted, again, opposite the inferior oblique muscle overaction. And you'll have poor elevation and adduction, and you'll treat for an abnormal head position and a vertical deviation from primary position or diplopia. And in this case, you'll weaken the ipsilateral superior oblique or the contralateral superior rectus to bring that eye down, the other eye down. So here you go, comparison of inferior oblique paresis versus a Brown syndrome. And this is one of those board questions as well. Again, although inferior oblique paresis is very uncommon. But with forced ductions, will be positive only in Brown syndrome, negative in the inferior oblique paresis. The strabismus in inferior oblique paresis is an A pattern versus a Brown syndrome, which is a V pattern. Remember that adduction on up gaze with the Brown syndrome. And superior oblique overaction, again, usually will be present in inferior oblique paresis because there's no opposed action of that superior oblique muscle, but not common in Brown syndrome, very none or mild. Monocular elevation deficiency, which used to be called double elevator palsy, and they're trying to slowly change our terminology here because they feel that's a misnomer, because monocular elevation deficiency is more commonly due to restriction rather than paresis. But in a situation where there's monocular elevation deficiency, you can have a paresis of both the superior rectus and inferior oblique muscle, for example, in a partial third nerve, okay? But 70% result from a tight inferior rectus muscle. Blowout fractures and things like that. Thyroid. Clinical features show a hypotropia of the involved eye, which increases in up gaze. They'll have a chin-up position. They're trying to fuse in down gaze. Frequently, you'll see a ptosis or a pseudotosis. Remember, the eye is fixating in a hypotropic eye, so the eye's in a downward position. So you'll have a pseudotosis present. So remember, if you're trying to evaluate if there's a ptosis present at all, you need to make sure you cover the other eye, let the hypotropic eye fixate, and then look at the position of your lid. Okay, it may just be solely pseudotosis present. And you want to differentiate those from a third nerve paresis, looking for other signs of a third nerve, pupil involvement of the medial rectus, involvement of the inferior rectus, to differentiate those. So here's showing a good monocular elevation deficiency. You can see a significant ptosis. But again, when we cover the fixating eye, you can see the eye refixates, the hypotropic eye fixates. She does have a little ptosis there, but most of it being a pseudotosis. But if you compare that lid to this lid, there's a mild ptosis present. Well, fairly significant ptosis, but much more severe when you see the pseudotosis. So here you can see she can't elevate in adduction, midline, or abduction. That's a monocular elevation deficiency. There's three types, restrictive again being the most common. This will have a positive forced adduction with elevation. They'll have a normal forced generation of both the superior rectus and of the inferior oblique. They'll have a deep eyelid fold on attempted upgaze because of that restriction, and they'll have decreased Bell's phenomenon because they simply can't get that eye up because it's restricted. With an elevator muscle weakness, there'll be a negative forced adductions, okay? There'll be decreased forced generations because of the paresis of the muscles, and they'll have a normal Bell's phenomenon because it's of a supranuclear origin. Or you could have a combination of both of those, where there can be positive forced adductions and decreased forced generations, depending on what the pathology is. The management would be surgery for large vertical deviations or for an abnormal chin-up position. Okay? With restriction, obviously, you're going to try to recess that inferior rectus so that to release the restriction. With no restriction, you'll need to do something for the paretic muscles. Okay? Since both elevators knocked out, you're going to need to bring something up into that area to create elevation so you can transpose the medial and the lateral rectus towards the superior rectus, and that's referred to a NAP procedure. And that, again, is a board terminology. You've got to know about that. Okay? So it's the medial rectus and lateral rectus transposing it up to the superior rectus. Orbital floor fractures can also cause vertical incomitant deviations, and hopefully you've learned a lot about this from the oculoplastics department, so I'm going to breeze through this a little bit and kind of point out some points. The blowout fracture with motility abnormalities will show limited elevation secondary to the entrapment of the inferior rectus muscle. Obviously, there's going to be forced adductions because of the restriction. You can get hyposthesia of the inferior orbital nerve. You can also get bradycardia, heart block, nausea, or syncope because of the vagal response to the entrapment. And here's showing a nice entrapment of that inferior rectus muscle. With an anterior blowout fracture, injury to the inferior rectus is frequent, and that can cause restriction to depression because of the paresis of the muscle. You can also get you'll diagnose this by forced generation, showing, feeling the weakness of the muscle. And in those situations, you'll want to wait and see if that muscle recover. The management of orbital floor fractures will include a CT scan to see what the extent of the floor fracture is. The entrapment may require early surgery, especially if there's bradycardia and syncope. Diplopia in those situations will be expected early. And then you'll observe the inferior rectus muscle weakness for recovery when there's no entrapment and wait about 6 months to see if that nerve will recover. If it doesn't recover, you're going to consider an inferior rectus resection and a recess of the ipsilateral superior rectus, possibly on an adjustable. You can also recess the contralateral inferior rectus on the other eye that's not involved, with or without a fixation suture, a Faden suture. And that's a really good technique because you're trying to equal the paretic muscle on the other eye by weakening that. When they go into down gaze, you weaken the contralateral muscle so they go into down gaze, basically dropping their head down to achieve down gaze and equalize those two weaknesses there. Or you can transpose the ipsilateral medial rectus and lateral rectus to the inferior rectus muscle if there's significant paresis there. All the neurological palsies I'm going to just touch on because hopefully they've been covered in the neuro-ophthalmology discussions, but they do create significant vertical incomitant deviations, so we'll touch on all of them as well. Third nerve paresis shows complete external paresis with limited adduction, elevation, and depression when it's a complete paretic third nerve. The eye is exotropia and hypertropia. And ptosis is often present with a significant pseudotosis because the eye is in down gaze. You'll see a myotic pupil when those third nerve paresis are congenital, and the adults will obviously commonly complain of double vision, especially if you raise their lid. In third nerve paresis, again, a board question, you want to be aware of aberrant regeneration, and this is misdirection of the damaged nerve. In this situation, you can get anomalous eyelid elevation, and showing in this picture when the eye goes into down gaze, the eyelid elevates. And that can occur in almost any direction. They can adduct the eye, and you can see elevation of the eye in adduction, or they can superduct the eye, and the eyelid goes flying up. You can also see pupillary constriction in any of those positions, okay, because of the aberrant regeneration. Or you may get vertical excursion of the globe when the eye is being moved horizontally. All misdirections. The management of third nerve paresis would be that you wait 3 to 6 months for recovery. You treat the amblyopia aggressively in a child, okay, because they will definitely get amblyopic because of the difficulty of fusing a third nerve paresis in most positions. The goal of surgery is try to get adequate alignment in primary position and slight down gaze for reading. Okay, adults are very difficult to treat. They'll sometimes get incapacity and diplopia because the field of alignment is so small. Children under 8 will usually suppress, so that's actually a good feature for them. And frequently I've got a lot of kids with third nerve, not a lot, but several kids with third nerve, and they'll frequently change fixation frequently because I've treated the amblyopia so well. So they'll change between the two eyes. The unfortunate problem is that when they fixate with the involved eye, the other eye will do the compensatory, upward gaze because they're fixating with the involved eye. So you try to limit that with surgery by decreasing as much as you can, trying to get that eye aligned as much as you can. But again, the area of alignment is so slim that there's going to be compensatory movement of the other eye when they fixate with that third nerve palsied eye. Fourth nerve palsies are less common in children than adults. Frequently, if they occur in adults, you need to consider a viral infection, but obviously an acquired fourth nerve paresis, you're going to do a neurological workup. These you can differentiate from Duane syndrome because there'll be an absence of the upshoots and downshoots. There'll be no retraction of the globe on adduction. And there'll be a presence of an esotropia in primary position that's proportional to the limitation of abduction. Okay? Meaning that if they abduct that eye, when I say fourth nerve palsy, sixth nerve palsy I'm talking about. Sixth nerve palsy. If they adduct that eye, if the sixth nerve paresis is significant, then you'll see a significant esotropia from that. That's in contrast to Duane's, where they may have significant lack of abduction, but only a very small esotropia. Okay? So that'll differentiate the two for you. It'll be very proportional in a sixth nerve paresis. The management of a sixth nerve paresis includes that there may be spontaneous recovery in about 50% of the patients, especially with traumatic if they're unilateral. You can use Botox onto the antagonistic medial rectus. This does not improve the rate of recovery, but helps them with alignment during the recovery. And you wait about 6 months for recovery of that muscle before you consider surgery. You'll consider a medial rectus recession or a lateral rectus recession or a combination of the two, depending on the amount of weakness of that lateral rectus. Or you may consider a transposition procedure if there's total paresis of that sixth nerve. Thyroid eye disease causes a lot of incomitant deviations, and this is secondary to edema and inflammation and fibrosis of the muscle due to the lymphocytic infiltration. You can confirm this, obviously, by the muscle enlargement seen on ultrasound, CT, or MRI, looking for that enlarged belly of the muscle. You can see it also here, a little bit there, but mostly here and here. These are most frequently bilateral and asymmetric. The forced ductions will be positive because of the restriction of the muscle. The inferior rectus is more involved than the medial rectus, which is more involved than the superior, and the lateral rectus being the least involved. So you'll commonly see an esotropia with thyroid disease or a hypotropia. They often have unilateral upper lid retraction. They frequently have upper lid retraction and proptosis, and as I said, a hypotropia and esotropia are more common. Common causes of acquired vertical deviation in adults, and especially in females, okay, so that you'll see vertical paresis in that situation, restriction. And they're rare in children. Thyroid disease doesn't occur commonly in children. And here showing the proptosis present, the significant upper lid retraction. In small cases of thyroid eye disease, you may use prisms to alleviate the early diplopia. If it becomes more severe, obviously prisms may be not advisable because of the significant hypo or esotropia, and you may need to patch the eye. You'll wait for 6 months for the stability of the thyroid eye disease before doing any surgery on them. The surgery will be indicated for diplopia and for abnormal head postures. Recession is the preferable method because of the resection will worsen the restriction of the muscle. Adjustable sutures are frequently used in thyroid disease, but I have to say when I've used them, very rarely have I had to adjust them, but frequently do use them. And you'll want to postpone strabismus surgery until after orbital decompression if the patient's getting close to needing an orbital decompression. Chronic progressive external ophthalmoplegia, or CPEO, is one of those, again, board questions. It's a progressive paralysis, usually starting at the eyelids and incorporating the extraocular muscles. It begins in childhood with ptosis. It can be sporadic or can be familial. You'll see an abnormal constricted visual field and abnormal ERGs, which can occur in CPEO. Usually there's no RPE changes when these happen. Or you can have what's called the Kern-Sayer syndrome. This is a frequently asked question on boards, showing the RPE changes, CPEO, and a heart block. This is showing you a significant CPEO, where there's just total limitation of movement in all gazes and a significant ptosis. And again, usually this is progressive, and you have no reason for the ptosis, you have no reason for the eye movements, and you'll just slowly see the eye movements go out. So you'll know it's CPEO, and there's no neurological problem when you evaluate them neurologically. Remember, again, board question is if you're suspecting CPEO, you want to evaluate the cardiac status, because that heart block can cause sudden death. There's limited options for ocular motility, for the ocular motility disorder, because again, all the muscles become wiped out. And you want to do cautious suspension of the upper lids to lessen the chin-up position, but more frequently, you want to watch for that corneal exposure that you're going to cause. Yes?
Tempo and laterality of the ophthalmoplegia, like which muscles go first? And
it can be highly variable, and both questions are highly variable. It can be any of the muscles involved, and it can extend over years or fairly quickly in a much shorter amount of time. So we've seen both. So very highly variable. Myasthenia can cause a lot of incompetence strabismus. It's common in children, but can occur. I diagnosed a 3-month-old with Myasthenia Gravis, but pretty uncommon in children. It may be purely ocular or part of a systemic disorder, and it causes weakening of the extraocular muscles and the levator. The diagnostic tests you want to know about, again, for broad questions, are lid fatigue with prolonged up gaze. Okay, have them look up for 2-3 minutes, try not to blink, and you'll see that the lid will just kind of slowly go down. You can use the sleep test, where they have the ptosis resolving after about 20 to 30 minutes in a dark room with the eyes closed. You want to look for the Kogan twitch sign, which is an overshooting eyelid. The patient looks down for several minutes. You have them look straight ahead, and you'll see the affected eye have the lid twitch up. Okay. The ice test I've used a lot for diagnosis, actually. It works wonderfully. You put ice on the eyelid for 3 minutes. You'll see improvement of the levator and sometimes improvement of the extraocular motility. Or you can still diagnose it with the Tensilon test, edrophonium or neostigmine. That's not commonly done as much because everybody is nervous about the cardiac status during those. But here's a good example of the ice test. I put ice on the involved eye for 3 minutes, and up goes the lid, and that's diagnostic for myasthenia. Management would mean that the ocular manifestations are frequently resistant to systemic treatment, especially in solely ocular myasthenia. When strabismus is stabilized, the eye muscle surgery can be helpful, okay? And you will get a lot of critiques from the neurologist when you're doing surgery on myasthenia patients. Oh, why is she doing this? But when you've maxed out all your ways of doing it, it's actually a very successful surgery. Remember, you're waiting till the myasthenia stabilizes. You're treating with them with prisms the whole time until the prisms just become unacceptable. A lot of these patients will have huge deviations. You put them in prism glasses. They've got a lot of optical aberrations from the prism because of a huge amount of prism you're putting in there. Remember, the deviation differs in all gazes because of the incompetency, so the only option is strabismus, and that is very successful, actually, in patients who have stabilized. You have to be careful, again, depending on the weakness of the muscle and how much you do to correct it, because you might need to do some significant tightening of the muscles to get the movement that you need on those weak muscles. Other causes for strabismus include refractive surgery to create monovision. I'm putting these in because they're not necessarily incompetencies or vertical deviations, but they are other causes for strabismus that you want to be concerned about. These will cause dissimilar images that disrupt fusion. Okay, that's also true with macular translocation surgery, which can create significant problems with fusion. Retinal detachment surgery, when you place those bands, be careful of where you're putting them and the involvement of the muscles, because you can create significant concomitant deviations, and occasionally we'll have to go out and take out some of those bands to get the strabismus to settle down. Aqueous draining devices, again, the big shunts. You want to watch where you place those, because, again, significant vertical strabismuses or incomitant strabismus can result. Botox injections can create incomitant strabismuses. Hopefully that is causative of what you're trying to do. If it's in a cosmetic situation, obviously you'll have to let the patient know that it will resolve, but unfortunately it'll take some time. And then pterygium removal or endoscopic surgery can also cause incompetency. Be careful with the pterygium removal and that insertion of the muscles sitting right next to where you're taking that pterygium off, so be very concerned about that. And unfortunately, endoscopic surgery, sometimes they go and transect the medial rectus muscle in medial sinus surgeries, and those muscles may need to be put back together, by causing, obviously, a significant incompetency. And that's all I have. Do you have any questions? Lots of information. Sorry for the eye-opener here, but hopefully I've made it more easy to understand. Thank you.